So what we should be able to do is finish up by going through esophagram, upper GI, and small bowel. That'll leave us with air contrast and solid column BE for next week. So in a lot of cases, we'll do these exams in conjunction. We'll do an esophagram, upper GI, esophagram, upper GI, small bowel, follow through. Sometimes the patient may get, the whole series and include a BE. Generally speaking, whenever we're doing upper GI, we're doing esophagram, upper GI, small bowel, we'll do those in that order. Typically though, if we're doing a BE to, also with everything else, we'll start with a BE, completely evacuate the patient as much as we can, then we'll go back and do the esophagram, upper GI, small bowel. So with the esophagus, if we're just doing the esophagus, there's specific pathologies that we'll look for. We'll look for that reflux, evidence of Barrett's esophagus. We'll look for diverticulum. We'll take a look at what some of those things look like as well. So with our esophagus, we can do AP or PA, doesn't really matter. We're not really looking to minimize any kind of magnification. What we're looking for is gross pathology. And also we're looking for flow of the fluid from the mouth into the stomach. So it could be AP or PA. It could be, we could do AP or PA oblique. The oblique is going to be very specific, and we can also do lateral. So what we're going to do is we're going to have the room set up. We're going to have thick and thin barium. We're going to go ahead and have some of the fizzies available, just in case we want that air contrast, or we're doing a upper GI in addition to, and we're also going to have some water. So you got to have something to activate those CO2 crystals, right? So you have to have some water to put it in. But what you want is as little water as possible. So when I say a little bit of water, I'm talking about just a couple of tablespoons of water in the bottom of a cup, so that whenever you throw those, this is essentially Alka-Seltzer. Put the Alka-Seltzer in, have the patient chug that, and then you have the patient start drinking the barium. May or may not do that on the esophagus. Most of the time you're going to do that on the upper GI when we start looking at the stomach. So you also want to have some water available because we can use that to evaluate for reflux. So you might want to have 2 water cups available, one just for the fizzies and one with a little bit more for the patient to drink to try to show that reflux. We'll talk about that when we get to it. So the difference between the AP and the PA is, in a lot of cases, simply the difference between you taking the overhead images and whoever's running the fluoroscopy, okay? So most of the time, if they ask for overheads, the patient's gonna get both PA and AP projections. So consider where your x-ray tube is in a fluoro machine. Where is it? What's that? It's inside the table, right? So if the patient's facing the image intensifier, then the x-ray tube's behind them, they're in a PA projection. So, and in most of the cases, once we get to the overheads, we're also going to have a patient in PA projection. So all of your views may be PA projection, PA oblique. May do AP, depending on the orientation again of the fluoro setup. Some of your fluoro setups actually have the x-ray tube on the outside and the image intensifier inside of the table. Most are not. And then we're going to do some laterals. So what we want to see is evidence of proper collimation. And get on a soapbox a little bit here and say that once we change from CR to a single size image receptor in a DR system, less importance on collimation. We've seen less importance on collimation. Used to, whenever you put the image receptor inside the table, it will collimate down to the image receptor size. So if you put 10 by 12 in, then it would automatically collimate down to the 10 by 12 size image receptor. The machine would automatically do that for you. It's what we refer to as positive beam limitation. There's automatic collimation. Since we have a single image receptor size though, it seems like we're having a tendency to open up those collimators just a little bit more, right, and overexpose the patient. So really encourage you to not use the entire image receptor for an esophagram. The esophagus is pretty easy to find, right? It's right at midline until it gets to the distal end. You can collimate in. Now, I'm not saying that you should collimate as small as a T-spine because it does make that deviation towards the patient's left-hand side. And if you collimate just to the size of a spine, you're going to clip the distal end. So it's going to have to be a little bit bigger than that, but it does not have to be a 17 by 17 image, full-size image receptor exposure. So make sure you get your collimation. What we want to see is from the lower portion of the neck, essentially at the epiglottis all the way to the stomach. So your distance-wise, you're going to use the entire image receptor unless you've got a very small patient or a pediatric patient. And we want the esophagus filled with barium. And how you're going to do that is not just by handing the patient, the cup and asking them to drink, because again, the stuff doesn't taste good, right? So if you're drinking something that you don't like, are you chugging it? Probably not. So again, once the radiologist is out of the room, I recommend you break out those big straws. If he asks for overheads, I'm just using he generically. If you're working with a female PA or a female MD, just plug that in your mind. But if you're doing the overheads, use those big straws. Have the patient, be able to take big gulps. And what you're going to do is you're going to align the patient. You're going to tell them to drink, but you're not just going to say drink. You're going to say drink, 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 and you're going to make your exposure, after you've said that a few times, just to make sure that the esophagus is as full of barium as possible. We want high kVp so that we penetrate the barium. So again, we're going to be using like 110 kVp. So the esophagus is going to be superimposed on the vertebra. For the PA or the AP, shouldn't be any rotation, except for just a little bit. If you remember back to the AC joints last semester, just the turning of the head obliques the patient just a little bit. You can't get away from that. The patient's head's going to be turned so that they can drink from the cup, right? So you're going to have just the smallest amount of rotation, but it shouldn't be obvious and much rotation at all. So your central ray is going to be T5, T6. Your collimation should be no larger than 12 by 17. Don't use the entire image receptor for an esophagus. Use more than a T-spine, but less than the entire image receptor. So top of the image receptor at the mouth to make sure that we get all the way to the epiglottis. So this is positioned probably a little bit low, but it's not a bad image. The esophagus is completely full. We see from almost the epiglottis all the way down to the stomach. So if you're just doing an esophagram, no overnight preparation is required. You don't have to have the patient take any kind of laxatives. Say NPO after midnight maybe, but the preparation for esophagus all by itself is pretty minimal. If you're doing an upper GI with a small bowel, now you've got to be NPO after the evening meal. If you're doing everything in conjunction with a barium enema, then you might actually have to have a patient take a laxative or possibly a cleansing enema or something like that. But just for the esophagus, you don't need that. Okay? So, again, you can do your obliques AP or PA. Most people do it PA. It's what we refer to as a RAO drinking esophagus. So what we're going to do is we're going to place the patient on their stomach, and this is after the radiologist is done with the fluoroscopy, and if they leave and they say, okay, I want some overheads, that's where we are here, okay? So they fluoro, they watch the barium, and they say, okay, I want a RAO esophagus, lateral esophagus. They leave the room. So now what you've got to do is you've got to get some of that thick barium, give it to the patient. The patient's probably going to be laying on their stomach at this point. oblique the patient into a 35 to 40 degree RAO position. And it's really going to be pretty easy to do. All you got to do is make sure you put the right arm down to the patient's side. Okay? If you have the right arm up like this and you go to oblique the patient up, what's going to naturally happen is they're going to roll up onto that arm and they're going to increase their OID. You're just going to get an ugly image. So take that right arm and put it down to their side. You're going to hand them the cup to drink from, and that's naturally going to rotate them up a little bit, you know, if they can get the cup close enough to their mouth, and then bend their left knee to support themselves on. Okay, 35 to 40 degree obliquity, RAO. You don't want to do LAO, you want to do RAO. If you're doing AP, then it's going to be LPO. Remember, RAO and an LPO, you know, basically the same, show the same thing. So RAO, most common. You're going to put your image receptor 2 inches lateral to the mid-sagittal plane on the elevated side. So my esophagus here, as I oblique up, you know, as I oblique up, no, went the wrong way. What's happening to my esophagus? Go more anterior, right? So naturally, what you want to do is you want to off-center. You know, your spine is going that way while your esophagus is going that way. So naturally, what you want to do is you want to off-center towards the patient's elevated side to try to put the esophagus in the center of the image receptor. So 2 inches lateral towards the upside is where you want to put your central ray. Okay? At the level of T5, T6. And then that should be what you get. So notice you're, you know, it's a little dark in here. Doesn't matter, that's not what we're looking for. We're looking for the esophagus. And again, that barium's hard to penetrate. But if you look at the difference in the ribs, you can tell that this patient, and the clavicles even, you can tell the patient is rotated into an RAO position. That's what you want to see. You want to see from the insertion below the diaphragm all the way up to the epiglottis. Okay, so notice where your central ray location is going to be. What's the difference between that, testing-wise, and the RAO during the esophagus?
Elevated, so.
Well, I mean the central ray location.
You need to move
The
it.
same place. The same place. Right. So the level of your central ray location is going to be to T5, T6. At a level of T5, T6 for both of those is what I'm getting at. So regardless, it's going to be T5, T6. Your centering here is going to be a very similar to the lateral of the T-spine. So what you want to do is you want to position much like a lateral T-spine. It really doesn't matter if it's left lateral, right lateral. Most people are going to do left lateral. Get the arms out in front of the patient, right? 90 degrees out in front of the patient. And you're going to center pretty much at the mid-axillary. Right? Pretty much just like a lateral T-spine. The main difference here, again, is you're going to have the patient drinking and not breathing. You know, lateral T-spine, we had the patient breathing. So what you're going to do is you're going to position the patient, both of these, you're going to position the patient, you're going to put the straw in their mouth, and while you're still in the room with the patient, you're going to say, okay, I want you to start drinking. And as soon as you say that, you're making your way over to the control panel. Drink, 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 rotor up, fire, okay, stop. And you rotate them up into the lateral, do the exact same thing, drink, 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 make your exposure. And then you tell them they can stop. And that's what your lateral should look like. And just like lateral T-spine, the upper portion is going to be very difficult to see because of the shoulders. Okay? So pathologies that we might see. Zinker's diverticulum is, anytime you see diverticulum, it's outpouching. And it's kind of like, everybody knows what an aneurysm is. It's where the blood vessel kind of goes boop. Well, kind of apply that to your GI tract. Well, it's not the entire GI tract that swells out. It's just little pouches, okay? So what they look like are, they look a little like, everybody's seen boxing movies where they hit the little speed bag, you know, look kind of like that, okay? So they got a stem and they got a pouch, and that's a diverticulum. The only difference between diverticula and diverticulitis is that with diverticulitis, something got down in there and caused inflammation. It's inflammation of a diverticulum, okay? So Zinker's diverticulum is a specific diverticula in the upper portion of the thoracic cavity off of the esophagus, okay? So the only one that I've seen personally looked like a patient had a second stomach in the upper portion of the thoracic cavity. It was massive. When we get down into the colon, the diverticula would be very small. They may have a lot of them, but they're going to be relatively small. Zinker's is going to be pretty big. The esophageal web occurs in the upper esophagus, and it may be precancerous, and what it looks like is kind of a ring artifact. As the patient swallows, we've got this web of material that causes a decrease in density just in that area, and it sometimes makes it look like, you know, there's like a zip tie tied around it. Cancer, if it's present, so let's say your esophageal web became cancerous, then what'll happen is that we get this appearance of a shelf, right? So it's as if the barium comes down and hits this thing, and then it has to, you know, kind of drip off of that. And it's not as dramatic as what, you know, I'm kind of demonstrating here, but it's a definite protrusion into the lumen, the hole of the esophagus. Achalasia is a very interesting appearance. That's what we refer to sometimes as tertiary contractions. That means contractions out of sync. So what you want is that whenever you swallow, you want your you want the contractions to be the same all the way around, so it grabs the food and it pushes it down, right? And with tertiary contractions, what we get is those contractions out of sync. So it may be pushing from one side here and pushing from the other side here, and it just doesn't move the food or the water very well. Okay, those are tertiary contractions. And what it looks like in a lot of cases is a corkscrew, like what you would take the stopper out of a wine bottle with. Okay, so corkscrew. Esophageal varices are varicose veins in the esophagus, and this is a kind of a weird one. All right, so esophageal varices occur. They have two different appearances to them. One looks like worm tracing. So you've seen like snails that crawl across the concrete or across the dirt, and they leave a specific trail, right? That's worm tracing. That's what the worm tracing looks like. And the other is what they refer to as rosary beads. It looks like a rosary that you would wear on your wrist. Rosary beads, it's got multiple filling defects. Atresia, I kind of talked about that when I was talking about duodenal atresia. Atresia is just incomplete esophagus, and the stenosis, again, is narrowing Barrett's esophagus, narrowing due to, in a lot of cases, reflux. So that's your Zinker's diverticulum. So what we've got is a first rib, second rib, third rib, way up in the upper portion of the esophagus. You got this outpouching, it fills up in the upper portion of the thoracic cavity. Esophageal web kind of has that zip tie appearance to it. We've got this little shelf sign here. That would be a cancerous issue. And that's your corkscrew esophagus. That's your achalasia. And then we've got both appearances here. I don't really see this as rosary beads so much, but I do really see how this appears as worm tracing. Oh, and I didn't finish my thought on this. So the esophageal varices, the mechanism of this particular pathology is what's weird. And that is generally liver damage. cirrhosis or hepatitis A, hepatitis B or C, you know, where they've got some liver damage. Your liver gets blood from the inferior vena cava, and it also gets blood from the portal vein. Okay, so it comes from the spleen over to the liver, but the liver can't process it as fast as what it should and as fast as what it used to. So the blood pressure is still building up, so we've got hypertension in the portal vein, and that manifests itself in esophageal varices. Kind of strange, the connection between the two. Atresia, a lot of different types of atresia. There's still a connection here, but the atresia can actually, a portion of the esophagus can join up to the airway, and that can be problematic as well. You know, look at this one here. Patient swallows, and instead of going into the stomach, it goes directly into the airway. Now you're looking at, again, aspiration pneumonia. So, stenosis. So another thing that we might see on both the esophagram and the upper GI is sometimes we'll get what we refer to as a hiatal hernia. I don't have any images of that, I think possibly at the end of upper GI. But a hiatal hernia can be diagnosed also on a esophagram. And a hiatal hernia is where you've got a portion of the stomach, the area where the esophagus punches through the diaphragm enlarges, and a portion of the stomach comes above the diaphragm. It could be very subtle, or it could be very dramatic. At some point in your career, you may take a chest x-ray on a patient who complains of just pressure, heaviness in the chest, and you take a chest x-ray on a patient, and what you'll see is over the heart, you'll see an air fluid level. You shouldn't have any air in your heart, right? So that's something else. And what that something else is going to be is what we refer to as an interthoracic stomach. So it's the entire stomach is above the diaphragm at that point. A rolling hiatal hernia is a hiatal hernia that kind of transitions between inside of the stomach and inside the thoracic cavity. We'll talk about diagnosis of that here in a minute. So any questions on esophagram? No? All right, so upper GI is just the study of the stomach. So what we may do is a scout, and the scout image is before you put any contrast in the patient, you do a scout image just to look to see where their anatomy is. Asthenic patient, how far down into the pelvis, how much do we need to open our collimators to make sure we see the entire stomach. If we have a hypersthenic patient, where is the stomach, right? So that's your scout image. So that's basically a KUB. Then we'll do, after we have a patient drink contrast, we'll take images of the stomach. So the questions on the test and the things that you want to see depend on what position the patient's in and where the barium is going to be with the patient in those positions. Okay? So I'm going to borrow this guy's head again. I'll go right here. There's stomach. All right, so the stomach, again, is J-shaped in most patients. Hypersthenic patients may be less J-shaped, but its orientation is primarily on the patient's left-hand side, and the distal portion of the stomach is towards the patient's right-hand side, right? So we have a tendency to think of the stomach as just being in a plane like this, but it's not, okay? So it's actually on the patient's left-hand side, this more towards midline, but the upper portion is also posterior, okay? So I'm going to leave the PowerPoints alone for just a second. We're just going to walk through this because it just makes it easier, I think, to get the visual. So the upper portion is posterior. So you're going to have to, in your mind, look at me and, I don't know, imagine that you're looking down from the ceiling and I'm laying flat on my back. Okay? Everybody got that mental? Okay. So if I'm laying flat on my back, so the questions on the test are gonna ask you two things. Where is the barium? Where is the air? So which is gonna be heavier, barium or air? Barium, right, so barium's gonna follow gravity. So whatever's closest to the floor, right, is gonna be full of barium. So if I have the patient laying flat on their back and I've filled the stomach up with barium and air, you know, we're doing an air contrast exam, the patient's laying flat on their back, where is the barium going to be?
Well, it's gonna be in the middle of the stomach, cause it dips down, the bottom.
The top. It's gonna be at the top of the stomach. It's gonna be a fundus. Right? This is gonna be anterior. This is anterior. So it's gonna be full of air. Right? So the distal portion of the stomach, pylorus, and the distal portion of the body is gonna be elevated. Remember, your eyes are ceiling, and I'm on flat on my back. So the barium is gonna rush to the fundus of the stomach. Right? And the air is gonna be in the distal portion of the stomach, possibly into the pylorus. Okay? So if I oblique into a LPO position, okay, have I done much? No. What's still posterior? The fundus of the stomach. Right. Fundus of the stomach is still going to be posterior. So where's the barium going to be? Fundus of the stomach. The air, again, is going to be in the distal portion of the stomach and probably more into the pylorus. Okay? So our projections are going to be AP, LPO. We're going to do a right lateral. All right, so now I'm just going to hold this up so I don't block the view. Right lateral, where is the barium going to be now? Pylorus. Right, it's going to be in pylorus, body pylorus, right? So if I oblique down into an RAO, have I done much? Not really. Not really. So it's still going to be in the body and the pylorus. These two views may be used interchangeably, okay? So in some patients, the RAO is going to be better. In some patients, the right lateral is going to be better, okay? So PA projection, okay? So now we're in PA projection. Make sure I get this right. Yeah. All right. Yeah. PA projection. Now where's the air going to be?
Fundus.
In the fundus. Right. It's going to be exactly the opposite of what it was in the AP projection. Now it's going to be in the fundus. Right? And where's the barium going to be?
In the body.
In the body. In the body. Right. That's upper GI in like 3 minutes. Okay. Now we just got to dial in what it is, or where it is that we're going to center. All right. So with an upper GI, we're going to have we already talked about the contrast. We're going to have somebody running the fluoroscope, all that stuff we've already talked about. So preparation though, we're going to need the patient to be at least NPO after midnight, maybe a diet, a meal the night before that's low residual, not a whole lot of roughage that may hang up in the stomach. Barium, unless patients go in surgery, obstruction, perforation, any of that kind of stuff. So intercalasis, I think we'll save to the end of the lecture, or possibly talk about that next week, because this is really a small bowel series exam. Okay. So the doc does all that stuff, and he leaves, right? And says, I want a full series. This is your full series. Sometimes doc may just, how personable they are, right? They may just turn around. You may have to ask, do you want any overheads? And if they say, yeah, full series, this is your full series. So what we're going to do is we're going to do a PA oblique, and a P oblique, and a lateral, and an AP. So we're going to essentially rotate the patient all the way around. What I recommend that you do on all of your barium studies, but especially once we get into the the bare minimas, is write down a logical order of, you know, the projections you need to take. You know, like if you memorize this and you say, okay, I need a PA, patient just drank all the contrast, I need a PA, what's opposite of AP? Or PA? AP, right, so you flip the patient around to AP. Got 'em, check, right? And you think, well, I need a PA oblique, and that's gonna be our RAO, right? What else do we need? LPO. Now you've rotated the patient twice. And what other view do you need? Right lateral, so you've rotated the patient 2 3/4 times. Right? Was that necessary? No. How about AP, LPO, right lateral, RAO, PA? How many times do you rotate the patient? Once. Right. So just write it down and then, you know, check it all off. All right, so again, think where's the contrast? That's where gravity's gonna be, or what's closest to the floor, right? So we want penetration of contrast, again, 110 kVp. We wanna see the entire anatomy. Evidence proper collimation, your collimated field should not be more than 10 by 12, with a possible exception of if you have an asthenic patient, you would be surprised at how long their stomach can be. It's crazy how long an asthenic patient's stomach can be. And also, if you have a hypersthenic patient, you may want to open a little bit wider. All right. So we want to shoot on expiration unless your radiologist is, you know, really wants inspiration. You can do them PA, recumbent or upright. You can do all your images recumbent or upright. Really recommend that you lay the patient down. You're going to off-center to the left-hand side, and you want to center your image receptor about 1 to 2 inches above the lower rib margin. That may be difficult for you to find. All right, so lower rib margins way down here, right? You start poking around on a patient way down here, and what might happen? It's ticklish, yes, they're going to run from it. So just up from that is what you get to what we refer to as the angle of the ribs. So where the angle of the ribs is where that costal cartilage comes into play, and your rib makes that dramatic turn, right? Right, unless you've got some patient with these really, really long arms. My dad had long arms, but even with him, that would correspond pretty closely to the bend of your elbow. His might have been a little bit lower than that, but not a whole lot, right? So if you can't find lower margin of the ribs, and if you can't find the angle of the ribs, just use bend of the elbow. Off-center towards patient's left-hand side, because that's where his stomach's going to be, with a possible exception of a hypersthenic patient. A really large hypersthenic patient may be closer to midline. Okay? So PA stomach, contrast is going to be in the distal stomach, air in the fundus. If you are shooting upright, then you're going to want to center a little bit lower because of gravity as the patient gets upright. Then the stomach's going to be lower. PA axial. All right, so now we get into specific exams for hypersthenic patients. So this is on page, I think it's 225. So PA axial projection, the only time that you're going to use this is on hypersthenic patients. And what you're going to do is you're going to angle 35 to 45 degrees cephalic. And this is what you want to pick up on the test all the way through the registry. It's used to open the high transverse stomach of the hypersthenic patient. Okay, just file that away. Used to open the high transverse stomach of the hypersthenic patient. Okay, so your PA, the stomach looks like that. Again, we've got the fundus. Fundus is full of air. Distal portion, the body in the distal portion of the stomach is full of contrast. So PA oblique, you're going to center to L1, L2. It's really going to be at the lower rib margins. You use the bend of the elbow if you can't find anything else. Rotate the patient 40 to 70 degrees, and that's going to be pretty dramatic. 40 to 70 degrees. is a pretty wide range of obliquity, and you'll see why here in a second. But what we're gonna see is contrast in pyloric canal and duodenum. And that is gonna be in your sthenic patients. Okay? Now the next one, no, that's your image. Fundus is full, body is full of air, body is full of contrast. No, not the next one. Lateral stomach. There we go. Alright, so lateral stomach then demonstrates the pylorus and the duodenum. I'm going to back this up in a second, but it demonstrates the pylorus and the duodenum in hypersthenic patients. Okay? So, some of your routines may call for lateral stomach in place of your RAO for hypersthenic patients. If it doesn't, and if the pylorus and duodenum are best demonstrated on lateral, in hypersthenic patients, rolling back to our positioning for our RAO, what do you think our degree of obliquity needs to be for a hypersthenic patient? Does it need to be closer to a PA, or does it need to be closer to a lateral? Lateral, right. So your hypersthenic patients, the larger your patient, the steeper you're going to oblique them up to 70 degrees. And then you'll do your right lateral to, better demonstrate it as well. Okay. So your AP oblique, that's your LPO position. You're going to position midway between the spine and the side closest to the image receptor. Midway between the xiphoid process and the lower rib margin. Again, if you center at the angle of the ribs or the bend of the elbow, you should be good. About a 45-degree oblique. Now we should see contrast in the fundus of the stomach. The rest of the stomach is going to be full of air. Lateral. Another thing you need to just kind of file away for your lateral is that what we can see on lateral is the area between the stomach and the vertebra. Okay, so we'll call that the retrogastric space. Okay. So any questions on upper GI? On the test, whenever we do get to the test, what I recommend that you do, you don't known each other for a full semester now. You should have embarrassed yourself in front of each other at least once by now. So, just oblique yourself. Just rotate your chair around. Try to picture in your mind where the image receptor is. Lean forward for PA, lean back for AP, right? And just picture the anatomy inside of the patient's body. Fundus is posterior, everything else is anterior. Where's the barium going to be? Where is the contrast going to be? Instead of memorizing each one of those, you can, kind of work your way through it on the test.
Is that what the main questions are going to be? It's like, where's the air? Where's the barium?
A lot of questions on this test on both the upper GI and the barium minimus. Yeah. So, somebody had something? I thought somebody had a question. All right, so upper GI pathologies, we talked about ulcers. We're going to have air contrast for demonstration of ulcers. Reflux, we can visualize reflux sometimes if we put the patient flat on their back and we've got their stomach completely full of barium. If we have the patient drink a little bit of water, and it's going to be kind of tough for the patient, you're going to have a bendy straw now because they're laying flat on their back, which is going to fill up the fundus of the stomach with barium, and you give them water to sip on. As the water goes down into the stomach, sometimes it'll it will regurgitate or reflux back up into the esophagus. So that's, a test for reflux. Sometimes they'll put the patient in Trendelenburg position, which means they're going to put their head down and their feet up a little bit. And that also is going to show some reflux. It also, though, can show the hiatal hernia. So by increasing the pressure at the junction, where the esophagus punches through the diaphragm, we increase that pressure, and sometimes we can have a little bit of that stomach come up above the diaphragm to demonstrate that hiatal hernia. If that doesn't work, sometimes they'll take a compression device like a palparium, it's an inflatable thing, and mash on their stomach, or have them lay on a towel roll or something to increase abdominal pressure, and that'll push it up as well. So a lot of different things that they'll use to demonstrate a sliding hiatal hernia. If it's an obvious and fixed hiatal hernia, they're going to see it anyway. But if it's a sliding hiatal hernia, they're kind of tricky. You fill the stomach up and you stand the patient up, and it goes below the diaphragm. You lay the patient down, fill the stomach up, and it may come up above the diaphragm. So any of those may help demonstrate reflux and hiatal hernias. And pyloric stenosis we already talked about. That would be what we refer to as an interthoracic stomach. We are almost out of time. So let me just explain small bowel series, and then we'll talk about enterocolitis maybe next week. So small bowel studies, if we're just doing a small bowel study by itself, there's no fluoroscopy at all. If it is a small bowel study, small bowel follow through to follow an upper GI, then what they're going to do is they're going to do all the overheads. They're going to leave, and then you're going to give the patient more barium to drink. Now it's going to be thin barium because we want to, we want it to go through all the way to the ileocecal valve as quickly as possible. So what you're going to do is you're going to give the patient 2 more cups of barium to drink in a lot of cases. If you're just doing the small bowel series all by itself, you're going to give them the 2 cups to drink. You're going to do a spot film or a scout film, right? You're going to do a KUB scout. Give the patient 2 cups to drink. They drink those just as quickly as possible. And your first image is going to be at 15 minutes. There's no point in shooting one right away because all the contrast is going to be in the stomach. So you're going to shoot your first image after your scout. Your first image is going to be the scout. Have the patient drink 1 image at 15 minutes. And then another image 15 minutes later. The first image you're going to shoot kind of like what you would shoot an upright abdomen. That would be to put the top of the image receptor about at the level of the axilla. So you're going to position about 2 inches above the iliac crest. You want to make sure you get the entire stomach. Every image after that, until it gets to the ileocecal valve, is going to be at the crest, just like KUB. Okay? So that's all you're doing for a small bowel series. You're just shooting image after image after image until it gets to the ileocecal valve. So generally you'll shoot 15 minutes, 30 minutes, and if it doesn't look like it's moved much at all, then your radiologist may say, okay, shoot every hour from this point forward. It may be 15 minutes for the first hour, and then 30 minutes, and then an hour. So depending on the movement of the contrast of the patient's small intestine is going to determine how many images you're going to take and how far apart they're going to be. So just all KUBs. So that's what it looks like. So notice your small intestine. You can kind of see the villi in the first portion. The further down it gets and the more concentrated the barium gets, the harder it is to differentiate. But you see these kind of a shadow of these big puffy things here? That's indication that we've made it to the ileocecal valve. It's difficult to see the ileocecal valve. You can't really see it. That might be it right there, but it might not be on this particular image. So sometimes what we'll have to do is we'll have to spot the ileocecal valve under fluoroscopy. So again, break out the palparium, compression device, try to mash around and see exactly where the two intersect, and you may have to shoot that with fluoroscopy. So, small bowel, just KUB after KUB. Pathologies, again, we've got stenosis, atresia, ulcers, there's pancreatic cancer, I talked about that, and that's where you see the C loop of the duodenum expand out. Diverticula, there is a specific diverticulum in small bowel, and that is at the ileocecal valve. You may have what we refer to as Meckel's diverticulum. That's an interesting little case. Meckel's diverticulum can take on the characteristics of a different organ system, like a vestibular organ. Ectopic, meaning out of place, ectopic vestibular organ. It's kind of weird. You can have cancer and then Crohn's disease as well. So, pancreatic cancer, C loop, huge. Diverticula, we got little pouches. Stenosis and atresia. Crohn's disease just looks like a mess. It's just a mess. So, I know that was kind of sprint through the small intestine, but really it's just KUB after KUB. Any questions?